Okay. Do you see the screen? Do you see the screen? It's okay for you?
Yeah, I can see it perfectly.
Okay, okay. So thank you for asking me to speak about the TriScore as the new risk score for an hospital mortality prediction after isolated tricuspid valve surgery. And I have slightly renamed the title, if it works. Sorry, I don't know why. Okay, as addressing tricuspid regurgitation, identifying the right patient at the right time, and to emphasize the crucial role of the TriScore in our daily practice. So TR is really a frequent disease, especially as patients, as population is going to be older. TR could be primary or secondary. It's mostly secondary TR or functional TR, secondary to remodeling of the right ventricle or the right atrium in more than 90% of patients. The more the severe is the TR, the worse is the outcome. And you can see here, no, mild, moderate, severe. And it's also true when you have more severe than severe that you can call very severe, massive, torrential. In fact, there is a continuum. More severe TR, worse outcome. If we look at this French registry, we can see that among patients with symptomatic severe TR, mortality rate at 1 year is approximately 18%, and mortality or heart failure readmission rate at 1 year is approximately 40%, meaning that it's a really severe disease with a poor outcome. However, most patients are currently only treated with diuretics. They are medically treated. When you use diuretic, it's like sweeping under the rug, meaning that you are efficient at this time because you are decreasing the overload, but you are not treating the mechanism of the disease. If you look at the international guidelines, on the left part of the screen, you have the American guidelines. On the right part, the European guidelines. For both, in the last guidelines, they suggested to refer patients with severe TR when TR is symptomatic or with right ventricular dilation if there is no severe right ventricular or left ventricular dysfunction and if there is no severe pulmonary hypertension. And they suggest surgery with a class 2A indication for both guidelines, knowing that, to be fair, there is no study today that shows that there is any benefit to treat patients. There is no study that says it's useful or it's useless. We don't have data because, unfortunately, you, the surgeon, you didn't work on this field to say if it's useful or not to treat the patient. And in the European guidelines, they have opened the door for transcatheter treatment, knowing that at this time, at the time of the guidelines, there were no study showing if it's efficient or not to treat those patients. So what I would suggest is this slide about how we should treat our patient. I think that when you have a patient with severe symptomatic TR without any right ventricular or left ventricular severe dysfunction, without any pulmonary hypertension, the patient should be referred to a heart valve center, not specifically for an isolated tricuspid surgery, but for a better assessment, a comprehensive assessment of the patient to define what would be the best strategy for each patient, a tailored strategy for each patient. And the first point would be to assess the surgical risk, and the TriScore could be or can be an effective tool to assess this risk. If you look currently at how many patients are referred for an isolated tricuspid valve surgery, you can see that the number of patients is very, very low. And one of the main reasons is that in-hospital mortality is considered as very high. If you look up, you have an American registry and they show the 8 or 10% in hospital mortality rate. And in this French administrative database, we had the same mean in hospital mortality rate of 10%. Unfortunately, when I did this study, I was very frustrated because you have the rate, but you don't know why patients are dying. And that is why I have built this first study, whose goal was to gather several centers. There were 12 French centers, 12 French tertiary centers, and I asked them to collect the data for all patients who underwent an isolated tricuspid valve surgery during an 11-year period. There were 466 patients. Approximately half of the population had functional TR, and approximately the other half had organic TR. And interestingly, we found exactly the same mean in hospital mortality rate of 10%. But this mean rate was hiding very I think, huge disparities between the groups. Indeed, if you look, patients with organic infective endocarditis had very low in hospital mortality rate, less than 5%, while this rate was very high, 16%, in patients with functional TR and prior left-sided valve surgery. But very interestingly, the mechanism, the etiology of TR was not associated with the outcome, contrary to the preoperative presentation, meaning the clinical, biological, and echocardiographic parameters. In cardiology and in cardiac surgery, we like scores. We have the STA score for aortic valve replacement. We have score for isolated mitral valve replacement, for mitral valve repair, but you don't have STA score for the tricuspid valve surgery. And if you look at the Euro score, and I had the data, you have only 85 patients that were that underwent an isolated tricuspid valve surgery. That is why we have built the first, and it's the only one, dedicated risk score model to predict in-hospital mortality after isolated tricuspid valve surgery for patients with severe TR, with 8 clinical, biological, and echocardiographic parameters that are very easy to ascertain: age, NYHR, functional class, right-sided heart failure signs, daily dose of furosemide, liver and kidney function, left ventricular and right ventricular function. For each parameter, you have 1 or 2 points, and at the end, for each patient, you will have between 0 and 12 points. When the number is 0, in hospital mortality rate is 1%, and this rate is increasing with the TriScore, with the number of points, up to 65% mortality in patients with at least 9 points. I think this is very interesting because, you know, we are always talking about the R team, the discussion. It's very important, the discussion in our team. But the truth is that this is based on real world. This is based, those patients underwent surgery. And if you look, if we add the TriScore a couple years ago, I assume that those patients would not have been referred for surgery. And I'm sure that if today you say to your patient, hey, you have a mortality rate that I can predict and it will be 2/3, 65%, I'm sure the patient would say no, and I'm sure that you won't even suggest him to go to the surgery. So we have divided the TriScore in 3 categories: the low risk for patients between 0 and 3 points, intermediate 4 and 5 points, and high TriScore for at least 6 points, and we are going to discuss about it. The score was an excellent discrimination, much higher than for the other scores, and an excellent calibration. Interestingly, you can see that patients with functional TR in red had a higher number of points, a higher TriScore than patients with organic TR in gray. And that explains why they incur a worse outcome, knowing that for each number of points, for each TriScore, in-hospital mortality rate is the same, whatever the mechanism, the etiology of TR. This score was built in France, okay, but there are several papers that have confirmed, that have validated the score, and you can see on the left part of the screen 4 centers in Spain with also an excellent area under the curve, and in the middle in Italy, in Milan, also an excellent area under the curve, and an excellent calibration as well. So our message would be that probably patients should be referred early in the course of the disease to the surgeon, while patients with intermediate or high TriScore should not be referred to the surgeon because in-hospital mortality rate is very high. If we look at other studies, for instance, on the left part of the screen from Leiden in the Netherlands and on the right part from Milan in Italy, they have the same results, okay, with other staging, and they both say that patients should be referred earlier, as when they are referred earlier, the prognosis is much more better. So the message is sooner rather than later, whatever your strategy. So this is a message that we'd like to transmit, but is it useful to treat our patient? Okay, so we have built recently a registry called TriScore, in which Leipzig, the cardiology department, is involved, whose goal was to evaluate whether the benefit of an intervention, of a curative intervention, and its modality, surgery, transcatheter, vary according to TR disease stage as assessed using the TriScore. So we try to compare survival rates at 2 years between the 3 treatment modalities: medical, surgical, and transcatheter valve repair. And I say valve repair because we excluded patients with replacement, transcatheter replacement, because the number is quite low, because there is the learning curve, and because the follow-up is too short. And for the surgical group, we took only isolated tricuspid valve surgery, meaning that we excluded all concomitant intervention. And then we assessed the TriScore to define the stage of the disease. And as I previously said, low, meaning between 0 and 3 points, intermediate 4 and 5 points, and high for at least 6 points. So finally, we enrolled 2,413 patients from more than 30 centers in 10 countries, patients with severe isolated functional TR on native valve. We took only patients with functional TR because transcatheter treatments are almost performed only for functional TR, and we would like to be able to compare the groups, and for whom the TriScore was available, and that was quite challenging as we need 8 parameters, especially the liver function with the bilirubin that was missing in many patients. So finally, more than 2,000 patients is quite a huge database. So 1,217 patients were in the medical group, 551 patients in the surgical group, and 645 in the transcatheter group. Interestingly, there was approximately 1/3 of the patients in each TriScore category. And if you look at survival at 2 years, survival at 2 years significantly decreased as the TriScore increased, the TriScore. So when the TriScore increased, survival decreased at 2 years. As I previously told you, there was approximately 1/3 of the patients in each TriScore category, and even in the transcatheter group, there was 1/4 of the patients in the low TriScore, which was quite interesting and quite surprising, but it allowed us to perform a statistical analysis. Like for the overall population, we had the same results, whatever the strategy, medical, surgical, transcatheter. Survival at 2 years significantly decreased as the TriScore increased. And an important message is to say that when the patient has a high TriScore, 40% of patients will be dead at 2 years. Okay, when you have high TriScore of 6 or more, 40% of the patient will be dead at 2 years, whatever the strategy. In the surgical group, 1/3 were repair, 2/3 were replacement. In the transcatheter group, 3/4 were edge-to-edge repair, and 1/4 was annuloplasty. So if we look overall, survival at 2 years between the 3 groups, there was no difference between the groups. And then we look according to the TriScore, and you can see there was a different TriScore category, but not in the intermediate and in the high TriScore category. Another point, important point, is in hospital mortality after surgery and after transcatheter valve repair. If you look at in hospital mortality after surgery, it was less than 3% in the low TriScore category. So it means very low rate of death. And this rate was significantly increasing up to 17% for patients with high TriScore. Now, if you look at patients with transcatheter valve repair, these rates were lower than surgery. It was less than 1% in hospital mortality in the low TriScore category, but it was up to 4% in patients with high TriScore, meaning that patients with low TriScore that underwent surgery had a lower risk to die than patients with high TriScore that underwent a transcatheter valve repair. So I think it's an important message. Low TriScore means low risk of mortality in hospital mortality. So we have designed a TriScore for surgery, but there are now several studies on the benefit of the TriScore among patients that are treated with transcatheter. If you look at this first study, because I will show you 3 slides with approximately the same results, but that are interesting, you have in gray the predicted in-hospital mortality rate for surgery, not for transcatheter. What you are going to observe in reality for after transcatheter, of course, is significantly lower, but you can find significant numbers in patients with high TriScore. And what is interesting is the 1-year mortality in blue, and you can see that there is a significant increase of mortality at 1 year after transcatheter valve repair that is quite concordant with the TriScore numbers with an area under the curve of 0.75. You have the same results in this other study, and interestingly, they found that patients with high TriScore incur a significant worse outcome. Another interesting point in this study is that among patients with low or intermediate TriScore, procedural success was associated with a significant improvement of death and heart failure hospitalization at 1 year, while even after procedural success in patients with high TriScore, there was no benefit, meaning that probably those patients are referred too late. And you have a third study that showed exactly the same result. So, of course, with the TriScore, if you say that in-hospital mortality after surgery is 10%, for transcatheter, it won't be 10%, it would be 5 times less, usually 2.5. But then, even at 1 year, you will have the same curves showing the mortality that is associated to the TriScore. And you can see that now the TriScore is among new publications with algorithm about the treatment of patients with TR, like in this review recently published, or the other one in the European Heart. So you can easily calculate the TriScore with the free online calculator, and soon you will have a dedicated app. So that was the first point, and if you agree, I'm going to speak about other points that are important to me, even if it's not about the TriScore. So the first point was the surgical risk assessment, and the second point is the feasibility and safety of transcatheter intervention. And you will need to work and to discuss about the anatomy and about the imaging, because image quality is mandatory to perform any transcatheter intervention, contrary to the surgeon that use his eyes and don't need imaging. So you have several tables or algorithms to define what would be the good or the bad candidate for transcatheter intervention. Imaging is mandatory. We are not going to detail about imaging, but you need several views to perform your interventions. And if image quality is not sufficient, now there's possibility to use intracardiac echocardiography that we don't use in daily practice because it's very expensive, but be interesting. And in the soon future, we will be able, when it will be CE marked, to use 3D and 4D eyes. That would be very interesting, especially for patients that for whom imaging quality with transesophageal echocardiography is poor. And at the end, when you have first the surgical risk assessment with a TriScore, and second the feasibility and safety of transcatheter intervention, then you will have the ultimate discussion to define what is the best strategy for my patient: surgery, transcatheter, or if there is futility, if the patient is a high risk for surgery, is not suitable for transcatheter, then we will discuss the medical therapy. And in the TriScore study, we compared surgery to medical therapy according to the TriScore. And interestingly, you can see that among patients with low TriScore, surgery was associated with a significant improvement of 2-year survival in comparison to medical therapy. So when the patient is referred for surgery early with a low TriScore, you have a benefit. That is a very important message. On the contrary, there was no benefit for patients with intermediate or high TriScore. Probably they are referred too late with a significant in-hospital mortality, and then you can catch this mortality rate. So in France, we are trying to decrease this risk, and there is currently a national study, a randomized study, to compare the levosimendan to a placebo to see if it could decrease the postoperative mortality. So I think that patients with low risk, low TriScore, they should be referred to the surgeon. On the contrary, patients with high surgical risk should not be referred to the surgeon, and you should discuss alternatives that are transcatheter treatment, that could be repair or replacement, mostly repair with the TriSclip, and you know the dilation of the tricuspid annulus at the level of the free wall. Reason why we are anchoring the clips in between the anterior and the septal leaflet, or between the posterior and the septal leaflet, and you can have either 2 clips anteroseptal or 1 anteroseptal and 1 posteroseptal. Last year was published the TriLuminate trial, randomized trial to compare TriClip and medical therapy. They showed that they were efficient to significantly decrease TR in approximately half of patients, but results were not so good in the other half. And at the end, they considered positive study because of quality of life that was improved, but we were a bit disappointed by the fact that there was no improvement in the 6-minute walk test. There was no decrease of mortality or heart failure admission at 1 year. So in France, we have exactly the same study that TriLuminate. It's called TriFR, like France. The study is over. The follow-up at 1 year the last one will be in 2 weeks, I think, and we are going to present the results at the next ESC Congress. If no, we'll come back to TriScore and we compare transcatheter valve repair to medical therapy. If you look, whatever the TriScore category, there was no benefit with transcatheter valve repair. So if we only look at this slide, like we looked at the TriLuminate trial, we can say there is no benefit to treat the patient with transcatheter therapy, and we can close the game. But with my colleague David Mescazetoun, who I conducted this study, we worked on a new definition of what could be the procedural success, and we defined procedural success as a residual TR grade of mild to moderate or lower, meaning a 2/4 at discharge. And you can see that surgery is very efficient, as 97% of patients had a procedural success, while in the transcatheter group, it was only 2/3 of the patient, even if we were in the most experienced centers worldwide. When we now look at the comparison between transcatheter valve repair and medical therapy, but considering only transcatheter valve repair with successful procedure, you can see a significant benefit for survival at 2 years for patients in the low and the intermediate TriScore, while there was no benefit among patients with high TriScore. If we now look at patients with transcatheter repair with unsuccessful procedure, logically, there was no benefit in any of the TriScore category, and it was even worse among those patients. So I would emphasize the importance of having an excellent result, achieving an excellent result at the end of the intervention, especially with transcatheter intervention. And you have here an example with a patient with torrential TR, and this patient, we implanted 2 clips at the anteroceptor level. If you look at the anteroceptor level here, there was an excellent result, but there was still a severe TR at the posterior level. And for these patients, we had 2 more clips, and at the end, we have 4 clips, as you can see. It was like a surgical stitch. It's not surgical, it's transcatheter. 1 clip, 2 clips, 3 clips, 4 clips. But at the end, the result was excellent. And 2 years later, the patient is still alive without any readmission for heart failure, meaning how important it is to achieve an excellent result, significantly decreasing TR. But there are some patients in whom you cannot achieve an excellent result. And for those patients, for instance, like this one, you may consider other strategies such as transcatheter tricuspid valve replacement. And in France, we can implement 2 types of transcatheter replacement. This one, it's a French device, and we had the pleasure to perform the first in human. It was 3 years ago with excellent results. And you can see here guiding with both fluoroscopy and transesophageal echo with 3D echo. So I think because there are many images. Okay, so you can see the deployment, what is quite easy and fast, usually take less than 15 minutes to perform the intervention. At the end, no residual TR, prosthesis that is well, the device which is successfully deployed with no significant gradient, no leakage, intra or periprosthetic leakage, and nice imaging with the CT. We have another device that we use nowadays. It's almost routinely, even if it's again in studies, a CE market study, with the Lux valve. It's a Chinese valve, and you can see how it looks in 3D after implantation, with the rabbit ears, with no leak at the end. And we can even treat patients with pacemaker lead. You can see here the lead and severe TR before the intervention, and at the end, no more leak, and pacemaker lead here that is jailed at the posterior level, and here a nice CT after intervention. I have spoken only about a native valve, but we have also shown that the TriScore was very reliable, very accurate for patients with redo intervention, meaning patients with prior tricuspid valve repair or tricuspid valve replacement. It was the only score that was associated with in-hospital mortality. It was excellent to predict mortality. And if you look here, patients with low TriScore, even for redo isolated tricuspid valve surgery, will have an excellent outcome at 5 years. So to conclude, I think that patients with severe TR should be referred to heart valve centers where you can perform any intervention, transcatheter surgical. You should assess the surgical risk assessment, and of course use the TriScore. And second, assess the feasibility and safety of transcatheter interventions. Nowadays, all patients are enrolled in registries or studies for surgery, for transcatheter repair, transcatheter replacement, because we are at the beginning of the story. So patients with severe TR who are symptomatic or with air ventilation should be referred, if it's clinically relevant, and I would like to emphasize the fact that usually patients with severe TR have a lot of comorbidities, and for some patients you are wondering if reducing TR will be really relevant for those patients. So benefit will depend on the stage of the disease, and patients should be treated as an early stage as assessed by the TriScore, and on the procedural success, and you should achieve the lower TR grade as possible. So early stage, you can assess it with a TriScore that you can easily calculate. And I will end with this illustration to explain to the patients. Usually I make a comparison with leakage at the saline, and I say, you know, when you have leakage at the saline, what are you doing? You are using a basin of water, and for us it's diuretics, and you are calling the plumber. For us it's the surgeon. Then the plumber is going to fix the issue, and you will have a normal life. But for severe TR, what are we doing usually? We are increasing the doses of diuretics, but without calling the surgeon. And then things are worsening, and because they are worsening, you are increasing the dosage of diuretics. And at the end, the issue is no more the torrential TR, rather than the damage on all organs, right ventricle, liver, and kidneys. And finally, probably it's too late to treat our patient at this time. So thank you for your attention. I hope I was clear enough. And maybe we can discuss about it if you want.
Yeah, thank you very much for the presentation. It was very interesting, and I mean, I congratulate you for the commitment in general in tricuspid research and the whole tricuspid field. As I told you, you are an expert in the topic, so it's a real privilege having your experience here. And I do have a few questions. I'm sorry that not so many people joined. That's because of probably because of the vacations time right now, because not many people are in the hospital, and those who stayed are probably on call or whatever. So anyways, I do have questions. My first question is, you told us a lot of, let's say, good things about the tricuspid score, the TriScore, and I think it's a great tool, but which are the limitations of this score? Like, where do we have to take?
Sorry, I don't hear you.
For whatever reason.
Yes, I hear you now. It's okay. Matteo?
Sorry, do you hear me? For whatever reason, I can't hear you. I'm sorry. Give me a second. I have to get my headphones. Give me a second, please.
Matteo?
Now I hear you.
You hear me? Okay, I hear you as well. So you have a question, sorry.
So yeah, my question was the limitations of the score.
Yes, of course.
Because I mean, it's a great tool. I think it's used, but which are the limitations of this score? What do you think are the weaknesses of the score? Where should we be careful, and in which patients? Maybe some kind of patients where it is overestimated the risk or underestimated.
I think there are several limitations, but not on the way we assess the risk. I think it's quite good for assessing the risk, but there are some parameters that are not in the score and that would be interesting. For instance, one parameter would be pulmonary hypertension, okay? But in fact, I removed it from the parameters because we are not good to assess pulmonary hypertension with transthoracic echo for patients with severe TR. And in the group, there were 40% of patients with torrential TR, laminar TR, for which it was not possible to calculate it. So if we would like to work on pulmonary pressure, we should perform right heart catheterization, as it was shown by Philippe Lourdes. But the goal of the score is, and we would like to make it very simple. What I want is that any doctor in daily practice can use it. Okay, I think it's sufficient for this. But of course, there are other parameters. For instance, if the patient is 95 years old, if the patient is very frail, if the patient has obesity, of course, there are many parameters that could be included, but it would be endless. What we wanted is to have few but useful parameters, and parameters that are inside the score, they are very specific. I was the first one to emphasize the role of diuretic dosage, for instance. It's the first score with diuretics, okay? Because it's not the same if you have a patient with severe TR who is under 40 milligrams of furosemide, for instance, and the same patients, but under 500 milligrams with the same TR. It's not the same patient, okay? And it was the first time we showed it. And then you have the right ventricular function, you have the liver function, the kidney function. So I think it's a good one. It's not perfect. Nothing is perfect, of course, but I think it should be in our comprehensive assessment of the patient and in the discussion in the art team. But of course, if everything was predicted by the TriScore, you won't need anymore the art team discussion. So I think you should use it as a tool, not more, not less, but you should consider it. And for instance, one argument is, as I showed you, patients with very high TriScore, they were referred to the surgeon. So most patients are not referred to the surgeon because we consider that high risk, while if we take those patients very early, they should be referred with excellent results. And on the contrary, patients who are referred too late, and then you have high rates of mortality. So I think this tool is very useful, especially for you, the surgeon, and you should insist on this to say, hey, I want the TriScore, it's not too late. I can do a surgery for this patient. And now, for instance, in my center, and I think it's the same everywhere when I discuss with colleagues, a couple years ago, isolated tricuspid valve surgery was very rarely performed. It was approximately between 2 and 6 patients per year. Okay, very few number. And now, for last year's, it was 14. Okay, it's not a lot, but we moved from 2 to 14. Okay, meaning that because many patients are referred, for the moment they're referred to me for transcatheter intervention. I say, no, it's not really suitable for transcatheter, and the patient is not so old, so the TriScore is low. Why not doing intervention with surgery? And then it works. And then my goal, and I hope you will have the same, is to bring this message everywhere to say you should refer your patients, refer every patient with severe TR, and then we'll assess the risk and also the benefit, because for some patients, it's futile to do intervention, okay? But the goal is to say, because at the end, if more and more patients are referred to you, then many of them, you will undergo a surgery. Some others, it will be transcatheter, and then for others, you won't do anything. But I think the message is that you should use the tool, and even for the cardiologist, a general cardiologist, he can calculate the TriScore and then say, hey, it's a low TriScore, it's severe TR. Hey, I should bring him to the surgeon. No?
Okay. And you were talking about the pulmonary pressure. I wanted to ask you, do you guys perform a right heart catheter prior to your surgical or interventional tricuspid procedures?
If you look at the guidelines, it's mandatory. It's a class 1 indication. And of course, there is no patient that is going to undergo any curative intervention, transcatheter or surgical one for isolated tricuspid valve, isolated tricuspid valve for severe TR without any right heart catheterization. Yeah, all patients.
So you always perform it?
Always.
Okay.
It's in the guidelines for pulmonary hypertension.
For pulmonary hypertension, yeah, because it is not in the It is not in the valve disease guidelines.
Yes, it's not in the valve, but if you look at the guidelines of pulmonary, it's written as class 1 indication for patients with curative, before any curative intervention, right heart catheterization should be performed.
I think it makes sense. I mean, it's super helpful.
Yeah, of course. And I think the most important point is not, in fact, it's not pulmonary pressure, because we don't care about pulmonary pressure. And usually what I'm doing is the patient come before, a couple days earlier, and then high doses of diuretics with intravenous doses of diuretics, so you can decrease pulmonary pressure to be below any threshold that would be a contraindication for any study. So we don't care, and I'm not cheating doing this, because the goal is that after the intervention, you will decrease this pressure, but it will be more about be sure there is no precapillary pulmonary hypertension. That would be a contraindication for this type of intervention.
Yeah, irreversible precapillary.
Exactly.
And it's also important the relationship to the ventricle function in terms of, for example, PAPS over TAPSE, for example.
That is an important point as well, because there is a lot of talk about this, and I think that it's very interesting, but if we would like to do this, it should be better. It would be better to use right heart catheterization pressure than echocardiography pressure. But it's interesting because in the TriScore, we are currently working on this, not with right heart catheterization, but with echo. And this publication, this paper, will be led by the Leipzig team, from the cardiologist. So I assume you are working a lot with them on this topic, and they will lead this project.
They are very active indeed in this topic.
Yeah.
Okay, so I have one last question, and then I can see if somebody else in the audience has questions. But it's related to tricuspid interventions, but not necessarily now the score is. We have seen here in Leipzig that after tricuspid surgery, our patients oftentimes have vasoplegia. Yeah. And we believe that it is related to the, let's say, once you close the tricuspid valve, there is a load increase of the right ventricle, and then you have a flow back to the cava and to the venous system. And then it sort of increases the pressure in the portal system, and at the end, finally, it creates a bacterial translocation. So we believe that this bacterial translocation is the cause for the vasoplegia after surgery, because we only see this in tricuspid patients. So we started doing in Leipzig a sort of antibiotic prophylaxis. So we give the patients oral antibiotics one day before we do the surgery, the tricuspid surgery. And we have, at least in our experience, observed that these patients develop less vasoplegia, and we don't see so many vasoplegias. But my question is, have you seen in the interventional arm of these procedures, after TriClip, for example, TriClip, this sort of a phenomenon, or like this sort of vasoplegias?
No, I didn't, but the fact is that I'm not considering patients with isolated tricuspid valve intervention like other patients. What I mean is that, for instance, for aortic valve replacement, the patient, it will come on Monday and the surgery will be on Tuesday, But for transcatheter intervention, in fact, there is a lot of pre-ab, okay? And I have made protocols. Some patients are going to, because usually for each patient, he will have high dose of diuretics before, and mostly intravenous diuretics. It could be done in hospital, or it could be done during hospitalization at home during several days or weeks. Okay, so finally, my goal is that when the patient is going to come at the hospital for the intervention, in fact, I will have decreased as possible the overload. So finally, after the repair, the placement, the transcatheter, the surgical repair replacement, there will be not so much difference of load before and after. It's what I'm doing, and honestly, it works pretty well. I did it at the beginning for transcatheter valve repair with the clip, because you know what I say is that when you have a huge gap, you don't have an excellent result because you are going to catch only a small part of the leaflet. While when you are decreasing the gap with huge doses of intravenous diuretics, you are decreasing the gap size. So then you are going to catch more leaflets, more tissue, and you will have a better result. And
Oh,
I
that's
think,
interesting. So you
and
think,
do the same for replacement as well, you know?
oh, that's cool. But that means if you want to do TriClip, it's good to have a negative balance of the patient so you can grasp more of the leaflets because
Exactly.
it's not so full, the ventricle.
Yeah, exactly. It's what I'm doing, and I'm currently working on it with the PCR TriClip focus group, and I'm leading a work on this.
Well, but that's interesting. That's maybe a strategy that we could also adopt for our tricuspid patients, for the surgical patients. Maybe like
It's what I'm doing also for surgery. Yeah, I think we have to prepare. And for instance, you know, but I don't know how to do this study. I think it's not possible. But I think that the TriScore will change for each patient. I give you an illustration. I had one patient, TriScore was intermediate risk, okay? It was not high risk, it was intermediate. So we consider this patient for transcatheter treatment. At this time, we had only repair. We didn't have replacement a couple of years ago. But the patient, he was not suitable for a TriClip intervention. So finally, he was not so old, intermediate TriScore, and but not suitable for transcatheter therapy. 70 years old. What would you do? Nothing or surgery? What I've done is that I have prepared the patient with high doses of diuretics during hospitalization at home. And a couple of weeks later, in fact, there was an improvement in liver function, in kidney function. And so finally, there was no more edema, signs of right heart failure. NYHL was 2 rather than 3 or 4. Okay, so we have prepared the patient. It was an intermediate risk, and then it was a low risk. And finally, surgery was okay. So what I mean is that if you prepare the patient, of course, if the patient has a 9, the TriScore is 9, you can do anything for this patient. But if he's intermediate risk, intermediate TriScore, and not suitable for transcatheter, if it's not too old, maybe you could improve things with a couple of weeks with pre-app, and you bring the patient in a better shape. And that is an important message from the TriScore. In fact, what is important is the clinical presentation at the time of intervention. So if you prepare the patient with less signs of right heart failure, with improvement in liver function, then probably things will get better. It's what I think. That's
interesting.
difficult to prove for each patient.
So, and how do you decide how much diuretics to give? Like, how do you have to control the weight of the patients, or like what do you tell the patient? What does the patient have to do at home?
In fact, I should, but the truth is that usually it's patients with severe TR. I use high doses of diuretics. Usually it's 255 milligrams
Okay, a lot.
every day during several weeks. But you know, I think I have approximately 500, no, not 500, sorry, 50 patients with these protocols, and it works pretty well.
Interesting. So, and I was thinking right now when you were telling me that, what if you have, for example, a patient with a low TriScore, and you think he's, according to the TriScore, a good surgical candidate, but the patient has a, let's say, moderately reduced right ventricular function and a pulmonary hypertension, which are per se a contraindication for surgery. Will you still operate them?
No, it's not. I think, you know, if the patient has a low TriScore, the RV function is included in the TriScore. The RV
Yeah, but
function,
you,
the RV
sorry.
function is an important parameter, but it's not the only one. So if the patient has only if the TriScore is low with RV function, it's already included. So the TriScore is low, it's low. And then pulmonary pressure, I think that pulmonary pressure, if you do the same right heart catheterizations 3 weeks after hospitalization at home with high doses of diuretics, probably there will be no more pulmonary hypertension. So if you prepare well the patient, then the TriScore will remain low and everything will be okay after intervention.
Okay, yeah, very
Prehab
interesting.
Prehab is for me very important. This is something
Yeah.
on which I'm trying to work. But you know, you can say survival rate is 1%, 10%, it's easy. But how to show how useful it is in a study, it's not easy, you know. It's more
Well,
by
but
experience.
this is one study we need to do. Prehabilitation against no prehabilitation in patients undergoing tricuspid surgery.
But it's not so easy because what is the most what is important is the clinical presentation as assessed by the TriScore. But what would be interesting is to say, but it's not possible because for the same patient to say, you know, the patient has a TriScore of 5, and then after 1 month of prehab, the TriScore becomes 3, and finally is moving from 16% to 8% mortality rates. It's difficult to assess.
Okay.
But I think there won't be any study on this, but with experience, it's what people are going to do. And finally, it will come by itself because it works.
Yeah. Okay. I mean, I could talk with you about this for hours, but I guess you want to go home. I don't know if there are any other questions from the few people in the audience. Fadi or Manuela, Maya, Miki.
Do not hesitate, of course.
Sorry again?
Do not hesitate if you have any question.
Oh, yeah. Well, they don't seem to have questions.
Next time.
Yeah. But again, thank you very much for your time and for the excellent presentation. It's actually a pretty interesting and exciting topic. So I'm happy we have you here, and I'm sure those who missed the presentation will watch it with the video, using the video. And again, my apologies that only a few people joined, but it's still a privilege to have you here. So I wish you a good evening, and thank you again.
Thank you, Matteo. Thank you to everyone. And I hope you will use the TriScore in your daily practice and especially in your discussion with the cardiologist. You should do this because patients with low TriScore, I think that surgeons have something to do with those patients.
Yeah, definitely.
Okay?
Okay, bye-bye. Thank you.
See you. Bye.